Hi, I'm Alicia Gonzalez. I'm an emergency medicine doctor and the clinical training lead here at the California Bridge program. And today we are going to talk about getting back to the basics, Bup 101, or perhaps longer stated, how to do MAT as a standard of care for patients with opioid use disorder. The California Bridge program is a part of the Public Health Institute. We are funded by DHCS and we're definitely nonprofit. Our goal is to get out here and help people do a better job saving lives. I don't have any financial disclosures, but I might say brand names, not so much on accident, but because our patients often refer to buprenorphine as one of its brand names, Suboxone. And I want to ensure that you're able to recognize that name as well, because patients will use that term. At California Bridge program, our goal is to have every hospital in California doing MAT as a standard of care from the emergency department by 2025. And we are well on our way right now in 2023. Ultimately, we want the whole country to do this. So wherever you are, this is all relevant to you. It's agnostic, but we did start in California and we're pretty proud of the work that we've done here. Why do we want to do this at all? Because in case you missed it, opioids are killing Americans. They are one of the #1 killers in our country, which is terrible and has been this way for almost a decade. We have millions of people who are still misusing prescription drugs and millions of people with diagnosable opioid use disorder. Despite all of our efforts to stop the growth in this epidemic, over 900,000 people, almost 1 million people, started newly using heroin in 2020. That wasn't that long ago, and that's a ton of people. And the reality is that every one of these patients is our patient. That's so many people that it's so pervasive in our community. And no matter what your specialty is, no matter what kind of patients you're seeing, a lot of them are going to have opioid use disorder on their problem list. And of all the things they're coming to us to seek care for, this is the one that has the highest risk of killing them. And so we have to do a better job meeting our patients where they're at with the answers they need in that moment. You might be somebody who's from a site that has done a lot of work in opioid stewardship, curbing your prescription habits, using alternatives to opioids or Alto in the treatment of pain. And if that's true, awesome, great. Prevention work is good work. The problem is, what we have seen is that as we nationally have decreased our opioid prescription rates, that's the shrinking purple bar that you see in this graph, it didn't stop the rising death rates, which is the blue bars that are getting taller on the top part of this graph. And that's because now illicit fentanyl is everywhere. And there is no amount of curbing our prescriptions or using opioids less in the hospital that's going to stop those illicit drugs from entering America and killing Americans. So we have to take our role in treatment as seriously as we take our role in prevention. To be able to do that, honestly, we have to get to a place in our hearts where we accept what science has already overwhelmingly showed us. And that is that addiction is a medical problem. It's not a moral failing. It's a chronic neurocognitive disease. Yes, it can be the result of unfortunate consequences of lifestyle decisions that people have made, but that's true of a lot of chronic medical problems. Take diabetes, for example. Most patients with diabetes had poor diet and exercise habits. Maybe they became overweight or obese and they developed insulin resistance and insufficiency and ultimately diabetes. We don't scoff at those patients or not treat them because it was their choices that led them here. The same is true for addiction. We don't scoff at these patients or judge them or give stigma in their direction because of the choices that they have made to get them where they are today. Instead, we offer medications to decrease the harm in their life, to save their life, to give them time on their own path to recovery so they can find their own way to live well. Our job is to replace the stigma that has come along with treating patients who use drugs for so many years and replace that stigma with evidence-based care. And to do that with every patient, every time, no matter where they're at in their own journey today. The California Bridge model has 3 major pillars that we think are critical in getting this work done. The first piece is low barrier, evidence-based medication for addiction treatment. And we're going to dive into this in just a second. The second piece, though, is connection to ongoing care and community. Specifically for us in California, we're referring to the role of the navigator or the substance use navigator, which is also work that's being done by social workers and care coordinators and case managers and nurses all over the country. But the idea being, it is our job in the acute care setting to start treatment, to stabilize the patient and their brain and their life but then to connect them to ongoing care in the community, resuscitate, stabilize, and connect to ongoing care. Because the healthcare system is really difficult to navigate, patients definitely need help doing that. And this is a very high risk community. So we have to have intentional navigation, intentional coordination of care for these patients. Finally, developing a culture of harm reduction, which is really two pieces. The first being person-centered, decreasing stigma, and wanting to do well and right by these patients. And secondly, giving our patients the tools they need to stay alive and to mitigate the risks that come from doing drugs in general. Now let's dive into that first pillar, low barrier access to evidence-based treatment, which we're going to walk through what we like to call at California Bridge, the quick start guide in just a minute. But the reason that we talk about doing this at all is because we know that the difference in mortality between somebody who is on medication for addiction treatment versus is not is extreme. If you look at the general population risk of death and you call it 1.0 as a marker, we know that people who use opioids have a 6 times risk of death over 5 years than the average population. If that same person, though, is on medication with buprenorphine or methadone, their risk of death comes down to only 1.8, less than 2 times that of the general population. That's a massive mortality reduction and should make us take this medication seriously. It's certainly better evidence than a lot of medicines that we use. Why is this our problem, though? Why is this an emergency problem, an in-hospital problem, an EMS problem? The reason is because this study showed us, and has been reproduced multiple times, but this study showed us that the risk of death I already mentioned for you for people who use opioids is high. It's especially high in those who have just overdosed. So if somebody who has just overdosed, was resuscitated with naloxone by EMS or in the hospital, those patients were trended and they were seen to have a very high risk of death in the next year. This makes sense, right? They just died and got naloxone and lived. It makes sense they'd be high risk of death. But of that group that died in the next year, a fifth, 20% actually died in the first month. And of that group, 20% died in the first 48 hours. Simply put, the highest risk of death for a person who just overdosed is in the next 1 to 2 days. That means that when they are right in front of us post naloxone resuscitation, they are at the most vulnerable they are going to be maybe ever again in their life. And we have an opportunity to stabilize this person, to save their life. This is like the TIA or high-risk chest pain or unstable angina of drug use. And so don't worry, I'm not advocating to admit these patients, but we do have to take them that seriously when we look at the risk stratification. There are multiple medications that are used for medication for addiction treatment, including methadone, a full opioid agonist, and including naltrexone, an antagonist. But we're going to really focus today on buprenorphine, a partial mu receptor agonist. I want to take a beat, though, to say this is not to knock the other 2 medications, especially methadone. Methadone is a really important evidence-based life-saving medicine. And if a patient is doing well on methadone, they should stay on methadone. And it might be the right medicine for some of your patients, too. But for practical reasons, we want to talk more about buprenorphine. Buprenorphine, again, is a partial mu receptor agonist. It helps our patients to feel more normal, and it kind of offers airway protection because since it's only a partial agonist, it has a ceiling effect for respiratory depression. There is no max dose for buprenorphine in the treatment of withdrawal for MAT. There is no max dose, but as you get higher and higher and higher in your bup doses, the patient's not going to overdose from bup alone. Now, if you mix buprenorphine with a bunch of other meds that can cause respiratory depression, alcohol, benzodiazepines, etc., sure, it can contribute to respiratory depression, but in and of itself, not going to cause overdose, which is a super attractive quality. Because it's a little bit safer in that way, patients also don't have to go every day to a methadone clinic or an OTP, an opioid treatment program. They can take home prescriptions for buprenorphine. It doesn't cause somnolence or altered mental status, so these patients are also permitted to drive a car or operate heavy machinery at their job or do things that are a little bit more just practical in their life than patients who are on a full agonist like methadone. Buprenorphine has a super high affinity for the mu receptor, so it will kick off any other opioid that's on there, including fentanyl, heroin, etc. So we do want to wait for the patient to be in withdrawal because if they're still high, the bup's going to knock them off that full agonist and bring them down to partial agonist level, which we don't really want to do. Not dangerous, not going to kill them, but not pleasant. So we do want them to be in withdrawal first. But the opposite is also true. If bupe is in their system and a patient uses fentanyl, that fentanyl isn't going to have as much of an effect because the buprenorphine is going to occupy that receptor first and not let go. So in that way, it's kind of an airway protector for patients who have bupe in their system. The half-life is pretty long. And so most patients in maintenance therapy end up being on once or twice a day dosing, whereas the pain medication part of buprenorphine rises and falls a little bit more short acting, like in the 4 to 6 hour range. This is a landmark study by one of the pioneers in this work, Dr. Gail D'Onofrio. And what she showed, like, why do we, again, care about this in the ER? What she showed was that if you take patients who are actively in opioid withdrawal and you start them on medication in the ER and then get them very close follow-up, versus if you take that same patient and get them, again, very close follow-up, but you wait the 24 to 48 hours to start that medicine in the clinic, if you were to give the medicine instead right away in the ER, you double the likelihood that that patient is in treatment at 6 months. So 78% of patients who got meds in the ER versus 37% who didn't start it for a day or two, and they all got the same follow-up, the same navigation. Twice as many stayed in treatment at 6 months if they got the medicine right away, right there in the ED. I already showed you that there's a huge mortality reduction with being on buprenorphine. So this means starting meds in the ED saves lives. Another way to look at this, number needed to treat. These are all items that I would consider standard of care, right? In a lot of what we do in medicine. And it only takes 2. The NNT is better for bupe, 2 people to keep in treatment, which we know treatment saves lives. So it's 2 people to save a life. That's better than aspirin and a STEMI. That's better than steroids and causing a bounce back in a COPD exacerbation. This is incredible evidence, and it's definitely safe and something that we should do. So the best news in this bleak environment we work in is that MAT works, and it's really easy to do. How easy? Well, let me show you. This is the California Bridge Quick Start Guide. If you scan this QR code or you go to cabridge.org, you can get a copy of this for yourself. But we're going to walk through it pretty quickly here. First, as mentioned, the patient has to be in withdrawal. If you're not comfortable with looking at a patient and knowing if they're in withdrawal, you can use COWS, the Clinical Opioid Withdrawal Scale, to help you make sure that they're in moderate to severe withdrawal. COWS, however, when measured against a trained clinician, is the same. So if you're pretty good at recognizing it and you're getting comfortable in this work, you don't have to calculate a COWS. It shouldn't be built into any like nursing protocols. It's just a useful clinical tool if you're less comfortable knowing what it looks like. But basically, you're making sure the patient has a COWS of 8 or above and some objective findings, just showing you that, yes, they are definitively in opioid withdrawal, moderate to severe withdrawal. You want to make sure the patient's not altered, right? The day they come in on polytrauma, that they're super sick, it's not the right day to talk about buprenorphine start. If they're in acute organ failure or if they're using methadone, these are not the right patients. But if the patient is here and their main complaint is symptoms of opioid withdrawal, or perhaps they have like an abscess or something simple and withdrawal is clearly part of their presentation, that's the patient, that's the time. We mentioned looking for high scores on the COWS, but really you also want to make sure you're seeing a hard sign, something objective. Do they have dilated pupils? Do they have tachycardia? Are they vomiting in front of you? Have they gone to the bathroom multiple times with diarrhea? Are they yawning? Do you see the runny nose and the watery eyes? Are they agitated, pacing in the room? Things that you can see just to really make sure in an era of fentanyl that you've waited long enough. Fentanyl can build up in people's adipose tissues, and so it takes a bit longer sometimes to truly enter withdrawal, and we just want to make sure that we're there. 1 or 2 objective findings, score of 8 or higher on COWS, and we are good to go. You're going to give that patient buprenorphine as a dissolvable sublingual dose. The medicine does have to be fully absorbed and in the mouth without going into the stomach. So unlike, for example, ondansetron, which can dissolve or be swallowed, this one's got to be oral. So nothing to eat or drink for the next 15 to 20 minutes. I recommend a little bit of water before you give the dose to make sure that the mouth is wet, but you want to give about 8 to 16 milligrams of buprenorphine. Personally, we are now recommending mostly starting with 16 milligrams or even higher because of fentanyl causing people to have higher tolerances. You do want to verbally screen for methadone, no methadone for 72 hours. That is because of the very long half-life of methadone. And as I mentioned, with buprenorphine being a partial agonist and having higher affinity, it will knock off methadone and replace it. And we don't want to do that. So just double check. If the patient does take any other respiratory depressant meds like benzos, you just want to screen for those. It doesn't mean you can't proceed forward. In fact, you should proceed forward. Please still start the bupe, but maybe that person shouldn't be in the lobby. Bupe in general is extremely safe. You could start a patient in the lobby. There are plenty of hospitals that have nursing-based protocols starting bupe in the lobby, but the patient who has co-occurring they also take substances that are respiratory depressants, maybe that person ought to be in the bed on a pulse ox. That's all. Nothing else special to do. You can still proceed forward. I mentioned this, but typically now we really are starting with 16 milligrams, just given how widespread fentanyl is. If your patient has a very high rate of use with fentanyl and they self-disclose that to you and they're saying anything in the realm of 1 gram or higher, a lot of us are starting actually with even 32 milligrams. We have proven multiple times, and there's good data out there that shows that rapid high dose bupe starts are safe. So don't be afraid to give the patient enough buprenorphine. You're going to wait about 45 minutes to an hour and then recheck the patient. If they're getting better at all, give another dose of buprenorphine. So let's say you started with 16, give another 16. You started with 32, maybe just give 8 more, but give at least 8 milligrams more to complete what we call the loading dose. You want to really get that patient back to feeling normal and to treat all of their symptoms. Most patients will really do well with a total loading dose between 16 and 32 milligrams, including patients who use fentanyl. Just be aware that patients with really heavy rates of fentanyl use, like in the gram, anywhere in the gram realm, 1 gram or more, they might require doses higher than 32 milligrams, and that's okay. There is no ceiling dose. You can keep going up, and you might have to do it more than once. So you see the patient, recheck, give another dose, recheck, give another dose until they're really feeling better. When they're finally feeling better, give just 1 more 8 milligram dose to seal the deal on that loading dose. If your patient's not better at all after multiple doses of buprenorphine especially, take a step back. It might be that you're still going down the right pathway, but just make sure you're not missing something else. Do they have DKA? Is it sepsis? Is it a viral syndrome? Are they withdrawing from something else like alcohol? Just make sure that you take a step back, because pure opioid withdrawal will respond to buprenorphine. Most commonly, though, the number one reason patients don't respond to bupe is that you didn't give enough bupe. So I want to reiterate again, don't be afraid to give the higher doses. Undertreated withdrawal is the most common reason somebody is getting sicker. Not to be confused with, but still on the differential, precipitated withdrawal. I know, I said it, everybody's most terrified P word, but precipitated withdrawal is not the same as undertreated withdrawal. Precipitated withdrawal is when a patient still has full agonist opioid, you give bupe, so it drops them down into the partial agonist category. It precipitates withdrawal. You know what this looks like because we do it on purpose with naloxone all the time. That's what precipitating withdrawal is. The person looks terrible, acutely sicker. It's almost like an excited delirium that's very unpleasant. They get acutely agitated. It's really like the word acute is the right word here. It's very fast, it's not great, and it goes pretty terribly. What I will say is it's really rare. There's some unpublished NIDA data that shows that of thousands of patients, I think about half of whom had self-disclosed fentanyl use, less than 1% of them when starting on high-dose bupe truly had precipitated withdrawal. So it's not common. What's way more common is not giving the patient enough. So let's say the patient has a heavy fentanyl use habit and you give 8 milligrams and then you go on your way for an hour and you come back. That 8 milligram dose was nothing like their 1 gram of fentanyl, and they're going to continue down the withdrawal pathway while your little buprenorphine dose didn't do a lot for them. Those patients are going to say it made me sicker or I got sicker after the medicine. But what they mean is I kept getting sick because I didn't get enough medicine. So it's because of not enough bupe, not caused by the bupe, whereas precipitated withdrawal is caused by the bupe. Why is there so much hype about precipitated withdrawal? Because it stinks. The patients hate it. They feel terrible. The provider feels like you lost trust. Your patient doesn't trust you anymore. And so we do need to put a little bit of effort into sort of consenting our patients and normalizing that possibility when we talk to them. To do that, I would just be really open with your patient. Look, I'm here for you no matter what happens. I wish I had a magic, wand I could wave with a medicine to make your withdrawal go away. And I can't do that. But I promise this is going to be the best withdrawal you've ever had if you just hang with me for a few hours. And I'm not going anywhere. I'm going to be here. If it takes multiple doses of medicine, then I'm here for it. I'm not going to abandon you, but I need you to give me some time. And just disclosing this. It's not like getting a dose of fentanyl where everything gets better right away. It's going to take some time. Also, openly asking patients, have you ever tried buprenorphine or Suboxone before? Sometimes they have, and they can tell you, oh yeah, one time when I tried 32 milligrams, I felt sick, but when I tried, I don't know, 64, I felt amazing. Well, maybe you should start with a really high dose in that patient. You can learn a lot from patients who have definitely tried it. If you do precipitate withdrawal, if it does happen, don't panic and don't let it stop you from doing buprenorphine, because all you really have to do is keep calm and give bupe and then some more bupe on top of that until you have fully saturated the receptors to get them out of the precipitated withdrawal and back into kind of that normal ranging category. To help with that, we recommend giving a single dose of a benzodiazepine oral, because that is a very stressful experience and it helps to have that benzo in your system just to kind of cool things off. So if you do precipitate withdrawal, immediately give your patient another 16, 24, even 32 milligrams of buprenorphine, right? Like your problem was you didn't go high enough to fully saturate. So give them a lot more. Give that oral dose of benzodiazepine. Don't forget about non-opioid medications, right? You have your NSAIDs, you have acetaminophen, you have antipsychotic medications, you have clonidine, you have all the other meds that you can give. And then some people like using subdissociative levels or analgesic levels of ketamine as another adjunct. But basically, you give these medicines to kind of help in the interim and give enough bupe until you've gotten yourself all the way there. Whether you precipitated withdrawal or not, at the end of this encounter, so you've given your patient their big full loading dose, now you're going to send them home with a prescription for 1 or 2 times daily buprenorphine. I often recommend starting with twice daily bupe, and they can kind of get settled down onto the right amount every 24 hours, and then go to once a day dosing with their primary doctor, with their MAT clinic. But I often send my patients home with 16 milligrams twice a day for at least 14 days. And if you're not sure how long to make that prescription, work with your team's navigator or your follow-up clinics to figure out how long it really takes to get into clinic. If it takes 3 weeks, give the patient 4 weeks of medication. If it takes 3 days, give 2 weeks. Why? People cancel their appointments or miss their appointments all the time, and patients' lives are being saved by being on this medicine. You'll notice that there is no more discussion about an X waiver, no special licensing. This is now a thing that you can do immediately as of this year, as anybody who has a DEA that includes controlled substances. No more X waiver. It doesn't exist. You don't have to give anybody a special number. Any DEA number covers this. If you can't remember any of this, or you're nervous, or you precipitate withdrawal, or you've got questions, if you're in California, remember that you can call Poison Control. They have toxicologists on call and specialists on call. They can walk you through buprenorphine starts or complications. Anywhere nationally, you also have the ability to call the National Warm Line, which is from 6 a.m. to 5 p.m. Pacific time on weekdays, but you can leave a voicemail 24/7 and it does get checked, and they usually call back within a few hours to help walk you through a patient case. It might not be as helpful in the emergency department, but certainly for our hospitalist colleagues, or if you're a primary care or surgeon or perioperative or any of that stuff, you can call and get some help in real time. Quick and dirty recap of this protocol. Patients should be in withdrawal. Make sure you're seeing some objective findings. Screen for methadone or other respiratory depressants. If they want help quitting or even just feeling better today, they don't have to commit to a lifetime of treatment. If they want to feel better today, give at least 16 milligrams buprenorphine. Wait 45 minutes to an hour, check again. If they're not getting any better, just make sure you consider a wider differential, but make sure that differential includes under treatment of their withdrawal. And if they are getting better, we still want to give at least another 8 to 16 milligrams of buprenorphine, complete that loading dose. No matter how much it took to get to that loading dose, most patients will do great with about 8 to 16 milligrams twice a day or once a day. Make sure you give enough in that prescription. They can go home, and you don't need a special license to do this. Make sure you get them enough medication to get to their next visit. What if your patient wants treatment, but they're not in withdrawal right now? Bupe starts are so safe that patients can do it all on their own. Here's a copy of the buprenorphine self-start protocol. Basically, it just mimics what I just went through as a hospital-based protocol, where the patient waits till they're in withdrawal and they start taking increasing doses of buprenorphine until they're feeling better, and they follow up in the outpatient setting. What about patients who are pregnant? Good news, it's all the same. The dosing is the same. The recommendations, the safety, all the same. There are more pregnancy-related deaths from overdose than from hemorrhage or preeclampsia. Opioid use disorder is one of the most high-risk complications of any pregnancy. MAT, however, with methadone and or buprenorphine, either of those medicines, is safe in pregnancy and breastfeeding and is recommended by the American College of Obstetrics and Gynecology. I want to bust a myth really fast. You do not have to admit patients to start them on buprenorphine if they're pregnant. It's not going to cause the mom to seize. It's not dangerous for the baby. In fact, baby has lower risk of neonatal abstinence syndrome if the mom is on buprenorphine. And most of the time when we're treating babies that have that anyway, it's just like consoling and cuddling them until they feel better. So in general, this is much more safe for mom and baby than mom being on illicit drugs or not being treated. So we don't have to admit mom to the hospital. We can just start her on the same doses. If she's in the third trimester, she might need to have higher doses because now her body mass index has increased, obviously, because she's two people instead of one. And you also should want to make sure that her labor and delivery plan includes continuing buprenorphine. Mom can get full agonist opioids or an epidural and all that stuff on top of it, but we don't want to take her bupe away because that will cause withdrawal and really difficult to treat pain. Speaking of pain, if a patient is on bupe and they're now in pain, they break their leg, they're in a trauma, they have an abscess, they have cellulitis, whatever, first and foremost, do not stop their buprenorphine. We can divide up their buprenorphine into more frequent doses so they can get the higher, the short-acting, higher rise and fall of the pain medication part of bupe, but we want to keep their overall 24-hour requirement the same. And we should have a low threshold for adding alternatives to opioids, right? Don't forget all those meds, NSAID, acetaminophen, gabapentinoids, etc. Or things like lidocaine nerve blocks, if it's a leg or an arm. Consult your ED team or your anesthesia or IR or somebody to see if that's possible, if that's the problem. And you can add full agonist opioids. In fact, we should not be afraid. It's very safe to do that, and we shouldn't make patients suffer because they're on MAT. Keep them on their MAT. Don't take it away. It makes pain way harder to treat. Divide up their doses into multiple doses a day if you need to, and add medications on top, including opioids if necessary to treat pain. Finally, when should a patient stop bupe? Well, I'm so glad that you asked. Frankly, they shouldn't. We don't always say, when is this patient with, diabetes going to come off their diabetes medicine or come off their insulin? Will some of them? Yeah, sure. Will all of them? No. By and large, most of them won't. Same with patients who have asthma. They don't just suddenly not need albuterol anymore, right? This patient's normal pathophysiology, their normal body physiology, depends on having low levels of opioid in their system. We know, and studies have shown us, that if you try to taper people off of buprenorphine, as opposed to leaving them on, their number of days that they return to illicit opioid use is much higher than patients who are kept on maintenance buprenorphine without tapering off. When you go back to use after you've been on buprenorphine for a while, your tolerance to illicit drugs is lower and your risk of overdose is higher. So in fact, not only should we keep people on their meds, taking them off their meds is dangerous and increases their risk of overdose and death. MAT, being on meds, is sobriety. This is the patient's baseline. So we shouldn't be constantly talking about when to come off your bupe or bupe until you're off of it. Tapering is not the goal. Treatment, living is the goal. Speaking of which, before we go, let's talk very briefly about harm reduction to ensure that we're really giving our patients the best counseling that we can when we talk about their drug use in general, with a couple of very quick tips. One is fentanyl is in everything. It's in stimulants and M30s. It's in all kinds of drugs and meds that are out there now. And so we want patients to know that there are ways to test their illicit drug supply to see if there's clandestine fentanyl in it. What I will say is that these strips are getting much better over time. There are some things that are not perfect about them, but they are getting technically better. They're just a little bit hard to use. It does require a little bit of know-how and some savvy and some technical ability. So they're not super accessible. They're definitely not the end all be all, but they can be helpful to the right patient. What is really accessible and super simple is Naloxone. We want Naloxone to be in the hands of every patient who uses drugs and every friend and family member of somebody who uses drugs. I keep it in my car. I hope you keep it on your person around you because you just never know. It's like the AED or CPR of 2023. And if this many people are dying, you just never know when you might be the person with the Naloxone to save the person at the mall or the restaurant or who knows where. There are programs in different states to help fund free take-home Naloxone. We know patients don't really fill their naloxone prescriptions only at about a 1 or 2% rate. And even with it being over the counter, it still costs money. And there's a lot of stigma when they go into the pharmacy to get that medicine. So look into your options for take home naloxone, get naloxone into everybody's hands, talk to your patients about how fentanyl is in everything. And finally, never use alone. Let our patients know that even if you are alone, there is this national hotline. It's anonymous. You leave your name and your location. You tell them what kind of drugs you're going to do. Hi, Melisha, I'm in this address and I'm going to smoke some meth. They stay on the phone long enough to make sure you don't overdose and there wasn't accidentally fentanyl in there. And if you become unresponsive, they send emergency personnel to your location, which is really, really cool. This is one item that I think is really important, and I will honor that not everyone is going to be in the same place receiving this information, but it is important to counsel our patients on how to decrease the morbidity and mortality associated with drug use. And part of that is safe injection. If you can get them to stop injecting, switch to smoking or something else instead, that's even better. But if they're going to continue using injection drugs, knowing how to do that in the cleanest, most sterile way. Do they have access to sterile syringes and needles? Do they know about syringe exchange services? Do they know how to use a tourniquet and that they should have alcohol swabs and not share their supplies with others? That they can get screened for hepatitis and HIV at maybe a local clinic. And if you're not super comfortable talking to patients about this, that's okay. There is a harm reduction coalition. The National Harm Reduction Coalition has a website, lots of great patient-facing material. You can refer your patients to there to get a lot of this information. But the point being, we can't get somebody into treatment if they're not alive. So helping our patients stay alive always gives us one more day until the day when they are ready for treatment, which we're working to make accessible to them. If you forget everything that I just said, good news, it's all available at the website, cabridge.org, and you can go there to access all of these clinical protocols and a lot more information. And if you need more information, email us, info@cabridge.org. Thank you so much for taking the time to watch this lecture, and way more importantly, for all the work that I know that you will do to help save lives and help our patients live well.